After that, there are some other special causes in which intrahepatic biliary canalicular system may not be functional, right? Can you tell me a disease in which autoimmune process specifically attacks biliary canalicular system and destroys it? These problems usually occur more commonly in females. Typically a female is in her 30s, her own 30s, and she develops severe jaundice progressively, building up conjugated hyperbilirubinemia, and she developed a lot of excoriations. Why excoriations all over her body? Itching, itching, itching. What do you think? What's wrong with that female? Don't tell me scabies. Scabies is possible with jaundice, but let's suppose in this case it's not scabies. There is a female. You should call her still young. She will be angry if you don't tell her. She is in 30s, and she has one husband and 2-3 kids. All of them need her these days, but suddenly she turned jaundice, conjugated hyperbilirubinemia. Along with that, she develops severe itching. Yeah, what could be the cause? There's an autoimmune process which is rapidly destroying biliary canalicular system, and if this process goes relentlessly, this will eliminate, really virtually destroy most of the biliary canalicular system, right? Initially you will find around the biliary canalicular system a lot of lymphocytes and plasma cells, then fibrosis and elimination, right? Okay, I'll give you one more pointer to the disease. Another pointer to the disease is, if you're really going to look for what is the autoimmune process, you must check autoimmune profile including anti-mitochondrial antibodies. These females are usually positive in anti-mitochondrial antibodies. Yeah, what is this disease called?
Primary biliary cirrhosis.
This young man knows. Primary biliary cirrhosis. What is primary biliary cirrhosis? Bile cannot be drained. So retained bile produces severe damage to the liver on chronic basis, and that chronic injury produces cirrhosis. And because it was not secondary to any stones or carcinoma, so doctor never knew what is the cause. They thought it is primary, but now we know it is autoimmune. Is that right? Primary biliary cirrhosis. So when you see a female in her 30s, right, of course younger and older females are not immune to this problem, but most commonly and classically it appears in 30s, right? And what really happens is she develops, why she was excoriating and itching all the time? You don't know. Because not only bilirubin is conjugated, bilirubin is going spilling to the blood, but along with that bile acids are also going. And bile acids are irritant to the mast cells, and low level of histamine produces severe itching. Is that right? Is that clear? So primary biliary cirrhosis is one autoimmune process which can produce a trouble like that. Then there can be autoimmune hepatitis also. Please don't confuse primary biliary cirrhosis with autoimmune hepatitis. In autoimmune hepatitis, autoimmune processes are directed against hepatocytes. In primary biliary cirrhosis, autoimmune processes are directed against biliary canalicular system. Is that right? So what we can say, that these patients may develop intrahepatic bile duct problem, and in this case there may be primary biliary cirrhosis. Can you tell me, usually autoimmune diseases are more common in females, or there are some autoimmune diseases which could be more common in males, Dr. Amtal? You don't know any disease, autoimmune disease, which is more common in males? Or do you know any autoimmune disease which is more common in males? Any idea? Just use the bank of your knowledge, right? In knowledge bank, in your knowledge bank, do you think all autoimmune diseases are more common in females, or are there some autoimmune diseases which are more common in males, more common in males than females? Dr. Tanzila, any? Write it down. There's a basic principle. All the autoimmune diseases which are associated with MHC class 2 molecules are more common in females. I will explain this in immunology. All the autoimmune diseases which are associated with MHC class 2 are associated in more common in females, like HLA, DR group. All the diseases which are associated with HLA, DR 4, 5, 2, they're more common in females. And right? And all the autoimmune diseases which are associated with MHC class 1 are more common in males. Thank God that those diseases are less, right? Autoimmune diseases which are associated with class 2 molecules are very common, and autoimmune diseases which are associated with class 1 molecules are less common, right? They are usually HLA-A or HLA-B or HLA-C. You have heard of diseases which are HLA-B27? For example, ankylosing spondylitis, right? That is more common in males or females?
Males.
Yeah, that is the most important cause of chronic backache in male. Females do have backache commonly, but if a male develops, young male develops chronic backache, you have to rule out, yes, ankylosing spondylitis. And another disease which is HLA-B27 associated, and in that case, biliary canalicular system is not destroyed, rather it is filled up by the fibrotic tissue. I told you in primary biliary cirrhosis, biliary canalicular system is attacked by the autoimmune system and then it is destroyed and disappears. But in case of the condition which I am talking now, it is more common in males, and in this case, autoimmune process specially attack the biliary drainage system and eventually produces chronic inflammation and all the system become fibrotic. Of course, when it becomes fibrotic, it cannot drain the things well. We call it sclerosing cholangitis. Have you heard of it? Sclerosing cholangitis, which is HLA-B27 associated, more common in males. Of course, it would be the cause of jaundice as well, right? There is a GIT condition with which sclerosing cholangitis is associated. What is that GIT condition? Yeah.
Ulcerative.
Excellent. I think you have it. Ulcerative colitis. Yes, he knows a lot about ulcerative colitis. He has the knowledge about that. Now, so what we are talking about, that there can be, okay, another cause of biliary, immune system specially attack the biliary drainage system. I told you, in young females, immune system may attack the biliary system and destroy it. Primary biliary cirrhosis. In young men, immune system may attack the biliary drainage system and make it fibrotic. That is called sclerosing cholangitis. And then we can talk about, another immunological process in which immune system attack the biliary system. Okay, I will give you a condition. You have to tell me the name of the condition. There is a patient who received a transplant. After receiving a particular tissue transplant, within few days, patient developed rashes, bloody diarrhea, and obstructive jaundice. This triangle you must know. Patient who received a graft. And what did he develop? Rashes, bloody diarrhea with obstructive jaundice. What is that condition, Mr. Kashif?
I'm not sure.
The transplanted tissue has attacked the host. This is called graft versus host reaction. When you transplant immunocompetent tissue like bone marrow transplant, when you transplant immunocompetent tissue to a immunosuppressed recipient, when you transplant immunocompetent tissue to the immunosuppressed recipient, immunocompetent tissue may attack skin of the person, mucosa of the GIT, and biliary canalicular system. This is a very classical triangle of graft versus host attack, which is called, yes, patient develop rashes, bloody diarrhea, and obstructive jaundice. Is that right? So, of course, that will also become a cause of what? Cause of jaundice. Okay, please tell me some drug, at least one drug, which can reduce the bile flow. Now, this is the time to be impressed. Do you know one single drug group which can reduce the, okay, I will give you a hint. Similar mechanism is involved, gynae of people know it a lot. So, similar mechanism is involved in pregnancy-related cholestasis. You know, there is pregnancy-related cholestasis, something like that. What is the mechanism? Okay, look at this young man and his IQ. He is saying if there is pregnancy-related cholestasis which occur at the advanced stage of pregnancy, is contraceptive pills. I think you don't know what is the function of contraceptive pills. They are not sweeteners in the mouth. You are thinking about what? The lady who is not pregnant. Let's come back to the lecture now, right? Yes. What is the reason? Anyone who want to tell me? high level of estrogen, and that young boy was not very wrong. When female have very high level of estrogen, now they know that sometimes estrogen levels, if they become very high, they disturb the biliary drainage system, right? In the same way, if female is not pregnant and taking oral contraceptives, again estrogen level is high, that can also produce cholestasis. So if I say which drug can produce cholestasis, please tell me. Oral contraceptive, but not in a female who is pregnant, right? Then we can come to extrahepatic biliary obstruction, right? Extrahepatic biliary obstruction. That's the easiest part of the lecture, which I love to talk about. What can be wrong with this system from here up to here? It's so simple. First of all, gallstones. Gallstones can produce obstructive jaundice. Usually it is fluctuating, right? Associated with upper quadrant pain, gallstones. Then there can be malignancies, yes. Malignancy of common bile duct, or malignancy of the head of the pancreas, or malignancy of ampulla of Vater, or malignancy of, so there can be malignancies. Again, there may be common bile duct malignancy, malignancy of the head of the pancreas, or malignancy of ampulla of Vater. Is that right? Then there can be strictures. What are strictures and atrasias, and how do they differ from each other? Common bile duct stricture, have you heard of this term? Or common bile duct atrasias. In atrasias, there is a congenital defect and common bile duct is not developed properly and it cannot drain well. Stricture is usually acquired problem. For example, you have produced a cut in common bile duct, removed a stone, and later on a stenotic fibrotic band is formed there, right? So what could be the causes? There may be stones, there may be cancers, there may be atrasias, there may be strictures, there may be choledochal cyst, right? There may be a cyst from this area developing and then pressing this, right? Choledochal cyst. And of course, do you know some flukes which love to accumulate into drainage system? You don't know any flukes. You know what is fluke? What is fluke? Please don't tell me cystosoma. Cystosoma involves the liver but does not produce this problem here. Yeah? Or is it cystosoma? I don't know. Something you should tell. I've told you so many things. There's one fluke, parasite, which involves the liver. And then it produces sometimes obstructive jaundice. How many flukes name you know?
Just one.
You know only one. Okay, that's good. I also know only one. Right? I'm happy to see you. So I know others also, but I'm not willing to share my knowledge right now with you. Right? So anyway, so some flukes, liver flukes, they can produce trouble here. Right? One of that fluke is also related, okay, let me tell you, one of those fluke is also related with causes of malignancy in the liver. Yeah. Oh no, you are going for far off places. Okay, you tell me tomorrow the name of that. Right? Okay, now we come. Okay, there's another very funny type of, I should say, worm. It's really like worm. There's a worm which may be present in your GIT, and sometimes, I don't know, somehow it navigates its tip into sphincter of Oddi, and sphincter of Oddi become tight around it. And then person develops what? Obstructive jaundice. You just tell me the name of that parasite. That's a round, yes, she knows it. Ascaris lumbricoides. How you know that? You read it somewhere or heard it?
Read it.
Okay, so she has read it at least about this thing, that there is a worm called here Ascaris lumbricoides, which is present in GIT, and sometimes it navigates its one end into ampulla of Vater, and then it irritates that area, and what will come? Yeah, sphincter of Oddi will become tightened around it, and there will be obstructive jaundice. Is that right? Of course, to diagnose this, you don't need to do ERCP. Fine? Talking about that, if you have, let's suppose you are running a center for the patients of jaundice, and many patients turn up to you. Now, just diagnosing jaundice is no diagnosis, right? It is just a state, and you have to find what is the underlying cause, what is the underlying mechanism, right? It's quite possible one person has jaundice due to mild hemolysis, another person has jaundice due to cancer, right? So, as a good doctor, you must know that you must be able to differentiate the people who have jaundice due to hemolysis, or people have jaundice due to decreased uptake of bilirubin, or who have jaundice due to impaired conjugation, or the patient who have jaundice due to intrahepatic cholestasis, or the patients who have jaundice due to extrahepatic cholestasis. Is that right? So let's talk about this thing. Basically there are three things which are important in regard to this thing. Number one, that in these patients, of course, you have to have some points from history. You have to pick up some points from physical examination. And in these patients, of course, very important is your laboratory work, lab work. Is that right? The laboratory results in which you have to talk about. So this is going to tell you about the diagnosis of a jaundice person. Right? Now, when we talk about the diagnosis of jaundice, let's do a little bit practice. First of all, suppose we talk about a person who has hemolysis, right? What will be the findings in him? Different type of indicators or pointers which will point towards the diagnosis. This person has hemolysis or he has jaundice due to excessive hemolysis, right? What will be the finding? Number one, in a patient who has hemolysis, what will be the real finding? First of all, we have to determine, is there any evidence of hemolysis or not? Is there evidence of hemolysis or not? If someone has severe hemolysis, then naturally his hemoglobin may go down, especially if bone marrow cannot compensate that loss of RBCs. Usually what happens, if someone has hemolysis and if bone marrow is very, very effective in erythropoiesis, it try its best to compensate. But let's suppose we have a patient who has severe hemolysis, is that right? And due to severe hemolysis, what really happens, that bone marrow has increased its erythropoietic activity, but still it cannot cope up or compensate for all the rapid losses, right? So his hemoglobin level will be, yes, hemoglobin level will be down in this person, number one. This is evidence of that RBCs are being destroyed or there's something wrong with the hemoglobin. Number two, in these patients who have hemolysis, right, naturally then we can talk about there are two types of hemolysis. Excessive hemolysis may be occurring within the macrophages or hemolysis may be occurring within the circulation. When hemolysis is occurring, excessive RBCs destruction within the macrophages, we call it extravascular hemolysis. We call it extravascular hemolysis. And if RBCs break down within the circulation, then what we call it? Intravascular hemolysis. Is that right? So another thing which is there, that hemoglobin is low, and if there is splenomegaly, what do you think? Splenomegaly points to? That points to extravascular hemolysis, right? Opposite to that, if, right, this is a feature of extravascular hemolysis, but if there is intravascular hemolysis, can you give me an example of intravascular hemolysis? Autoimmune hemolysis may be vascular or extravascular. For example, in some autoimmune diseases, autoantibodies are, you can say, coating the RBCs, and these RBCs, which are IgG coated, they are trapped in the spleen, and then macrophage take them up, then it will become an example of extravascular hemolysis. But in some cases, like ABO incompatibility, of course, RBCs may undergo massive destruction within the circulation. That is an example of intravascular hemolysis. And when you have intravascular hemolysis, what will be the feature there? Number one, you will have hemoglobinemia, free hemoglobin in the blood. We call it hemoglobinemia. Number two, when free hemoglobin is released in blood, normally hemoglobin is not present in free form in the blood. Hemoglobin is packed within RBCs. Free hemoglobin is present in the blood, right? Then naturally what will happen? It will bind with certain proteins. The protein which is released by the liver to bind with the free hemoglobin, which is a toxic molecule, right? That protein is called heptoglobin. What is the name of that protein? Heptoglobin. So what really happen in these patients who have intravascular hemolysis? That number one, there will be hemoglobinemia. Number two, haptoglobin level, free haptoglobin level will be down. Haptoglobin is a protein which is released by the liver, and usually it is present in circulation. The main function of the haptoglobin is, whenever there is intravascular hemolysis, it will bind the hemoglobin molecules. And naturally, when haptoglobin becomes loaded with the hemoglobin molecule, free haptoglobin levels go down. So whenever your blood free haptoglobin levels are down, it means there is intravascular hemolysis. Then, if intravascular hemolysis may be acute or may be chronic, it may be acute or it may be chronic. There are many ways to differentiate them. One of the way to differentiate them is that if there is acute intravascular hemolysis, then naturally when RBCs will break down, what will happen? Hemoglobin molecules will come out. Hemoglobin is a tetramer, right? But it breaks down into free form into dimers, and these dimers can easily, go into filtrate, and they are very small. So as these are passing down, they will make, number one, these dimers may be taken up by proximal convoluted tubular cells, right? And if proximal convoluted tubular cells, if they take up this hemoglobin, there may be acute tubular necrosis because it's toxic to these cells. There may be acute tubular necrosis because these molecules may be toxic to proximal convoluted tubular cells. This is number one. Number two, what really happens that if there's a lot of hemoglobin coming down, then there may be, there will be hemoglobin urea. Excellent. So acute hemolysis may lead to, of course, clinically it may lead to acute tubular necrosis, and on investigation you may find hemoglobin urea. And another thing, this is acute hemolysis, but if there is chronic hemolysis, there is chronic intravascular hemolysis, right? If there is chronically hemolysis is occurring within the blood vessel, what will happen? Of course, other things are same. Hemoglobinemia, reduced haptoglobin level. With that, there will be hemoglobin urea. But listen, hemoglobin urea will be also there. Hemoglobin urea. But there will be one special feature. What is that? That if there is chronic intravascular hemolysis and proximal convoluted tubular cells are chronically taking up the hemoglobin, then they will develop the capacity to to synthesize apoferritin and fuse the apoferritin with the iron released from hemoglobin. In this way, these cells develop a capacity to synthesize ferritin and polymerize the ferritin to make hemosiderin. So whenever someone has chronic hemolysis, he will develop a lot of hemosiderin formation within the proximal convoluted tubular cells, and then these cells which are loaded with hemosiderin may shed into tube, and then they appear into urine, and we say that there is hemosiderin urea. Excellent. There is hemosiderin urea. In acute cases, again, let's compare first of all that hemolysis may be within the circulation or within the macrophages. If hemolysis is within the macrophage, we call it extravascular hemolysis. If it is within the circulation, we call it intravascular hemolysis. The major feature of extravascular hemolysis is splenomegaly. In case of intravascular hemolysis, what really happens, number one, free hemoglobin is present in the blood. Number two, haptoglobin level will go down. Along with that, if it is acute case, there may be feature of acute tubular necrosis and hemoglobin urea. Even there may be cast, hemoglobin cast, right? But if this is chronic intravascular hemolysis, patient may develop not only hemoglobin urea, but with that patient may have hemosiderin urea as well, right? Now, in this particular patient, let's suppose person who has hemolysis, number one, in hemolysis what happens? Hemoglobin number go down. Number two, RBC count goes down. Number three, in these patients, what really happens? Unconjugated bilirubin will go, RBCs are breaking down now. So total bilirubin will go up. First of all, total bilirubin will go up, and out of the total bilirubin, which will go really up? Unconjugated bilirubin will go up and conjugated bilirubin will be normal. Is that right? Total bilirubin, right? They have high, and usually this unconjugated hyperbilirubinemia, in case of if your liver is functioning well, then unconjugated hyperbilirubinemia usually does not exceed above the levels of 5 to 6 milligram per day. Again, let me repeat it. If there is excessive hemolysis, right, but if liver is functioning well, hepatobiliary system is functioning well, then usually this type of hemolysis, which is resulting due to unconjugated hyperbilirubinemia, this usually does not exceed the levels of 5 to 6 milligram per dl. It means it is almost always mild jaundice. It is almost always mild jaundice. But if someone has under these circumstances having severe hemolysis, along with that, if hemoglobin unconjugated bilirubin level has gone above 6 milligrams per dl, you must think of probably there is something wrong with the liver as well. Is that clear? Now, bilirubin is high. Then these patients have more problems. What will happen? That there may be features of that bone marrow is trying to compensate. For example, reticulocyte count may be high. Retic count is high. It means this is a feature of bone marrow compensation. And when bone marrow is rapidly producing RBCs, the fresh RBCs which are released in hurry, they're slightly larger and slightly bluish tinge. So when they're slightly larger, we say there may be mild macrocytosis. And if RBCs are having unusually blue shade, we call it polychromasia. So macrocytosis and polychromasia occurs along with high retic count when bone marrow is trying to compensate for the RBCs which are rapidly being destroyed, right? So we have seen a person who has low hemoglobin, low RBC count, total bilirubin has gone up, dominantly unconjugated bilirubin has gone up. With that, if patient has hemoglobinemia with low heptoglobin, is that right? Hemoglobinuria, right? It is showing which type of hemolysis? Acute hemolysis, and it is also showing that bone marrow is trying to compensate. The reticulocyte count is going up, macrocytosis, slight macrocytosis, slight polychromasia is present as well. Is that clear? Now, in this particular patient, there will be no evidence of liver damage. If person's hepatobiliary system is perfectly okay. For example, whenever hepatocytes are injured, listen carefully, whenever hepatocytes are injured, hepatocytes are very rich in a special group of enzymes. What is the name of these enzymes? These are transferases or transaminases, right? One is AST. AST stands for aspartate transferases or aminotransferases, and other group is, yes, ALT, alanine transferases or transaminases. Some people call them transferases, some people call them transaminases. Now in this diagram you must remember AST and ALT are present in the hepatocytes. Because these are present within the hepatocytes, so we also call them hepatocellular enzymes. Actually, these enzymes are marker of hepatocellular injury. These enzymes are markers of hepatocellular injury. What is really meant by that these enzymes are the marker of hepatocellular injury? It means that whenever hepatocytes are injured, whenever hepatocytes are heavily injured, these AST and ALT, they will spill into circulation. AST and ALT. Out of them, remember, ALT, L for liver. It means it is more specific for liver diseases. AST is not as specific for the liver diseases. So whenever there is significant acute hepatocellular damage, then hepatocellular enzyme will spill into you can say circulation, and we say that serum transaminases or AST, ALT level has gone up. Here it is very important to understand that if there is acute hepatocellular necrosis, then AST level, then ALT levels are usually above the, yes, they have gone so high that usually they are more than 10 times the normal value. Again, let me tell you, if you find AST and ALT levels in a patient more than the 10 times value of the normal values, right, you must think in terms of acute hepatocellular necrosis. For example, it may occur in viral hepatitis, which is really severe one, right? So this was one point which is very important. So we can say that rising AST, ALT, especially when it is more than 10 times, it points towards the acute hepatocellular injury, right? Another thing which is important here, you see there are some other enzymes which are present over here. These are called alkaline phosphatases. These are present on the canalicular side of the hepatocyte membrane or in the biliary canaliculi. Right. When there is obstruction to, whenever there is obstruction to bile outflow, bile salts will accumulate and they will interact with these alkaline phosphatases, and these alkaline phosphatases will get detached and they will also go to circulation. Right. So it means alkaline phosphatases especially regurgitate to circulation from biliary canalicular system when the biliary outflow is blocked, because whenever there is biliary outflow blocked, cause may be mechanism number 4 or mechanism number 5, right? There is intrahepatic or extrahepatic cholestasis. Whenever intrahepatic or extrahepatic cholestasis is present, what really happens, these alkaline phosphatases, right, they are, you can say, acted upon by the bile salts, and they get detached and from these areas, membranes, and they spill into circulation. Even these membranes increase the synthesis of alkaline phosphatase. Usually with alkaline phosphatase, there is also another enzyme which is normally secreted by liver cell. This is called gamma glutamyl transpeptidases. Gamma glutamyl transpeptidases. So gamma glutamyl transpeptidases, another enzyme which is released by this is 5-nucleotidases. Nucleotidases. Now look, if there is cholestasis, if there is obstructive jaundice, what really happens? Not only alkaline phosphatase will go to the blood, even gamma glutamyl transferase will also spill to the circulation. Even 5-nucleotidases, nucleopeptidases, again let me repeat it. First was, what was this? Alkaline phosphatase. So whenever there is obstructive jaundice or there is any degree of cholestasis, alkaline phosphatase will spill to the circulation. Number 2, after that what will spill? Gamma glutamyl transpeptidases, and along with that even 5-nucleotidases may also spill into circulation. It means these three, serum alkaline phosphatase, along with that, yes, what was the second enzyme? Gamma glutamyl transpeptidase, along with that 5-nucleotidase. These three are the markers of hepatobiliary obstruction, markers of biliary canalicular problem, right? Markers of canalicular injury, canalicular obstructive problems. Now we can see, if someone has injury to the liver cell, what will spill into circulation? AST, ALT, transaminases. And if someone has injury to biliary canalicular system, what will spill into circulation? Alkaline phosphatases, gamma glutamyl transferases, and along with that there may be 5-nucleotidases. Is that clear? Having said all of this, I would like to introduce one more concept, that alkaline phosphatase enzyme is released by other tissues as well. Alkaline phosphatase can be released by the liver. The sources of alkaline phosphatases may be liver, or it may be bone, or it may be GIT, or alkaline phosphatase source may be, it may be placenta. Is that right? Now, so serum alkaline phosphatase may go up when there is obstructive or infiltrative diseases of liver, or when there are bone turnover is very fast, or postprandially after the food, or from the placenta. But all these enzymes which spill into circulation, they are different isotypes. They can be differentiated from the electrophoresis. These alkaline phosphatases which come from different sources, right? These can be electrophoretically separated from each other. Due to that reason, it's very important to know that if a person has raised serum alkaline phosphatase, what is the source? One of the simple way to know that source is liver or not, that if only serum alkaline phosphatase goes up, but GGT and 5-nucleotidases does not go up, it means probably the source is other than liver. But if someone has raised serum alkaline phosphatases along with GGT, along with 5-nucleotidases, of course, this must be coming from mainly from liver, right? Another point which I want to specify about the GGT. I told you GGT level goes up whenever there is some degree of obstruction or canalicular damage. Whenever there is biliary canalicular damage, GGT levels in the blood go up. In another condition also, one condition is when there is biliary canalicular injury, Another reason of raised gamma glutamyl transferase is alcohol intake. The people who take a lot of alcohol, right, in their liver, gamma glutamyl transferases are induced, right? Alcohol intake increases the concentration of and production of gamma glutamyl transferases, and then gamma glutamyl transferases appears into circulation. Now listen, if you end up with a patient who has a lot of gamma glutamyl transferase but not other liver markers, it means he is taking alcohol, right? Or some other liver drug which is enzyme inducer. Or if someone has gamma glutamyl transferase along with other enzymes as well, it means gamma glutamyl transferase has gone up due to obstructive reasons or canalicular injury reason. Is that right? After what, in a nutshell, what we can say, that marker of hepatocellular injury is, yeah, AST, ALT. Out of that, ALT is more specific because AST is released by other tissues, not only from the liver. And marker of canalicular injury is mainly serum alkaline phosphatase, but along with that, there is serum level of gamma glutamyl transferase and 5-gamma glutamyl transpeptidase and 5-nucleotide levels also go up. Is that right? Then another thing which I want to introduce here, that if your liver has lost its synthetic functions, if liver has lost its synthetic function for a short time, right, it will not produce, you can say, yeah, what it will not produce? Coagulation factors, and prothrombin time will be prolonged. So prolonged prothrombin time is a marker of synthetic failure of liver, and if your liver function, synthetic function is fluctuating rapidly, prothrombin time in the patient will also fluctuate. But remember, prothrombin time depends on vitamin K dependent factors. And if you have obstructive jaundice, it means bile acids and salts are not going to GIT. It is quite possible that fat is not getting digested and you are not getting back. Vitamin K is not being absorbed because it is lipid soluble. And if vitamin K is not being absorbed, simply reduced supply of vitamin K to liver can also lead to prolonged prothrombin time. So if a patient has liver disease, you are not sure that prothrombin time is prolonged either due to synthetic failure of liver cell or it is due to obstructive problem. Very easy way to rule out. What you do? That you inject the person with vitamin K. You inject the person with vitamin K and wait for 24 hours and again check the prothrombin time. If it is normalized, then it was due to deficiency of vitamin K, right? And if it is yet still prolonged, it means synthetic functions of the liver have gone down, right? Another point which I want to highlight at this very moment is that coagulation factors have a short half-life. Due to that reason, whenever liver function is fluctuating hour by hour or day by day, prothrombin time also fluctuate along with that. Then another marker of liver synthetic capability is serum albumin. But serum albumin protein is a very long half-life, about 20 to 25 days is the half-life of serum albumin. It means if my liver stopped working today, If my liver stop working today, of course, within 72 hours, my prothrombin time will be prolonged, but my serum albumin level will not go down. But my serum albumin level will not go down. So if someone has really low serum albumin due to reduced synthetic function of the liver should be having problem acute or chronic? Chronic. Is that right? So we can say short-term marker of synthetic capability of liver. Short-term marker of yes, synthetic capability of hepatocytes. What is that? Prothrombin time, once you have ruled out the vitamin K deficiency. And long term, yes, long term, what is that? Marker of synthetic capabilities of hepatocyte is serum albumin level. Is that clear? Now let's recap. We have one patient, he has severe hepatocellular injury. What markers will rise in the blood? AST? ALT. We have another patient who has severe obstruction to the biliary system. What main markers will go up? Along with its friends like 5-nucleotidase and gamma-glutamyl transpeptidase. Is that right? And if someone has a hepatocyte dysfunction and this synthetic ability of hepatocyte is reduced for a short time, what will really prolong? Prothrombin time. If someone has his synthetic capability of hepatocyte significantly reduced for many months, he will have prolonged prothrombin time? Yes. Along with that, he will also have hypoalbuminemia. He will have hypoalbuminemia. Is that right? Now about the liver, you should know 4 things very clearly. Number 1, AST, ALT is a marker of hepatocellular injury. They should be considered significant when their levels are more than 10 times of their normal upper values. Number 1. Number 2, if AST level is double than the ALT and both are raised, this is considered a marker of alcoholic injury to the liver. Write it down. When AST level has gone, AST, ALT both are elevated, but AST level is double or more than the ALT level, it should be considered alcohol mediated injury to the liver, right? So whenever you damage the liver cell, what spills out? Serum transaminases, AST, ALT. And if biliary obstruction occur, what spills out? Alkaline phosphatase and its friends, GGT and 5-nucleotidases. And whenever there is only short-term synthetic failure of the hepatocytes, what is that? Prolonged prothrombin time, once you have ruled out vitamin K deficiency. And if someone has prolonged synthetic function failure of the liver, he will develop not only prolonged prothrombin time, but he will also have hypoalbuminemia. That is why low albumin is considered a bad prognostic indicator of cirrhotic patients. It is considered a bad prognostic indicator of cirrhotic patient. Now, having said all of this, let's come back. Patient who has just hemolysis, but he does not have, you can say, yes, he does not have hepatocellular injury. Serum transaminases will be, serum transaminases mean AST and ALT will be normal. Then, what about markers of hepatobiliary injury? Yes, serum alkaline phosphatase will be normal, GGT will be normal, 5-nucleotidase will be normal, right? But the total amount of bilirubin which is loaded to his liver is normal or more than normal? So when it is conjugating more than normal amount of bilirubin, it means that more bilirubin is going, conjugated bilirubin is going to the urine. More conjugated bilirubin is going to the, to the GIT. More conjugated bilirubin is going to the GIT. So production of stercobilinogen is more. So stool may become dark color, and even urobilinogen production is also increase, and urinary urobilin levels also go up. Is that clear? Urinary urobilinogen also goes up. But because the bilirubin which is raised is unconjugated bilirubin. Which bilirubin is raised? Unconjugated bilirubin. And because this bilirubin is plasma protein bound, so can it spill into urine? No. So it means there is no choluria. Choluria means bilirubin coming into urine. So this type of problem is called acholuric jaundice as well. This type of jaundice is called acholuric jaundice as well. Acholuric jaundice as well. Is it clear? Right? Now, again let's come back to our first group of patient. What was wrong with him? There is evidence of hemolysis, right? Hemoglobin is going down, RBC count is down, total bilirubin is high. Dominantly it is unconjugated bilirubin. Bone marrow is compensating. For example, reticulocyte count is high, slight macrocytosis is seen, polychromasia is seen. No evidence of hepatocellular injury, AST, ALT normal, no evidence of biliary canalicular obstruction because alkaline phosphatase, gamma glutamyl transferase and 5-nucleotides are normal. Prothrombin time is, why it is prolonged? Prothrombin time is normal. Even serum albumin level is normal. Serum albumin is also normal. Serum albumin is also normal, right? Now, with that, urinary bilirubin is absent. Urinary bilirubin, because unconjugated bilirubin does not appear into urine because it is complex with plasma proteins. So urinary bilirubin is absent. That is why we call it acholuric jaundice. Jaundice is there, but bilirubin is not appearing into urine. But urobilinogen is more than normal. Is that clear? So this is a case, we can say a sort of prehepatic jaundice. Prehepatic jaundice in which liver function tests are absolutely normal except that unconjugated hyperbilirubinemia was there, but that was due to excessive production of bilirubin, unconjugated bilirubin due to hemolysis. Now we go to another patient. Let's go to the extreme. After having discussed about case number 1, now we go to the case number 4 and 5. Is that right? We are going to now discuss a patient who has obstructive jaundice, right? Or if you really want, we can go to case number 3. What do you think? It is very easy. Case number 2 is reduced uptake. You can understand no features of hemolysis, no features of hepatobiliary injury, simply unconjugated bilirubin is high, right? Case number 3. Case number 3 is the patient who has severe hepatocellular injury. Dominant injuries to hepatocellular area with some degree of intrahepatic cholestasis. So what will happen in case number 3? This case will be a typical case of acute viral hepatitis, right? Now when we talk about this case, that in this case either some drug or autoantibodies or you can say some toxin has damaged the hepatocytes significantly, right? Then what really happens? Number 1, what will happen to total bilirubin? This is case number 2. This was your case number 1. Case number 2, yes. For example, he has severe viral hepatitis, or due to any reason he has severe hepatocellular injury. Number 1, no features of hemolysis, features of excessive hemolysis. I must say, what hemolysis? Yes, excessive hemolysis. Another thing, in this patient, of course, no features of increased erythropoiesis. For example, there is no increased retic count of macrocytosis or polychromasia. Is that right? But When you do liver function test, you find total bilirubin is increased. Out of this, unconjugated bilirubin is mildly increased, but conjugated bilirubin is more increased. But the real marker of hepatocellular injury is level of aminotransferases. So what you really find, there is a very high level of AST, aspartate transferases, and ALT, alanine transferases. They are very, very high. So this point towards the real diagnosis that there is something wrong with the hepatocellular system. With that, if there is too much damage to the hepatocyte, but short term, then prothrombin time may be prolonged. And if unfortunately hepatocellular injury is for very long time and hepatocyte mass has gone too much down, right? And if hepatocyte count, cell count is very much down and mass is very much down, and then what really happens? Even albumin level will come down. But in acute hepatitis, albumin levels remain normal. Is that right? Then we can say that in these patients, the features of biliary obstruction are not there. There is slight increase in serum alkaline phosphatase is slightly increased. Gamma glutamyl transferase is slightly increased. Yeah, what was that third? 5-nucleotidase is slightly increased. So there is a heavy increase in AST, ALT, and mild to moderate increase in canalicular enzymes. So we can say primary target of the injury is hepatocytes, not the biliary canaliculi. Biliary canaliculi may be suffering secondary to hepatocellular injury due to dysfunction of this face of the hepatocyte or due to swelling of the hepatocyte compressing the biliary canaliculi. Then in these patients, what really happens? That about urobilinogen may be normal or decreased or slightly decreased, but it is usually present if there is not full scale cholestasis, right? So again, when you come to the group number 1 and 2, you find that markers of liver cell injury are normal and markers of canalicular injury are normal. But when you come to the case number 3, right, what really happens, that markers of hepatocellular injury are very high, 10 times the normal value, and there is mild to moderate elevation and markers of canalicular injury. But we come to the case number 4 was what? Obstructive jaundice, especially intrahepatic cholestasis. Right? First I will talk about that intrahepatic or extrahepatic cholestasis. What are the findings which are present in biliary obstruction? Then I will tell you how to differentiate basically problem is intrahepatic or extrahepatic. First of all, it's a very simple thing. When a patient comes and you want to know is it obstructive jaundice or not, what is the simplest test? Who will tell me? If a patient comes, patient is jaundiced, if your senior says please confirm is it obstructive or not, what is the immediate test you can do in 10 minutes in the ward? If patient is cooperative enough to provide few drops of urine, you just dipstick and see. If urobilinogen is absent, it is cholestasis, it is obstruction. Because if there is severe obstruction, intrahepatic or extrahepatic, it means nothing is going to GIT to be converted into urobilinogen. So the simplest and very you can say rapid determinant of what? Of obstructive jaundice is that simply on dipsticks you check the patient's urine, and what will be the marker there? If it is obstructive jaundice, urobilinogen will be absent, and if urobilinogen is there, obstructive jaundice is ruled out. Is that right? Then obstructive jaundice is ruled out. Now let's talk about obstructive jaundice and its related parameters. What will be the features of obstructive jaundice? In case of obstructive jaundice, number 1, total bilirubin will be, yeah, high. Is that right? out of that unconjugated bilirubin may be slightly high, but conjugated bilirubin will be very, very high. Is that right? Number 2. In these patients, markers of hepatocellular injury, AST and ALT will be slightly high, right? But markers of canalicular injury, that is serum alkaline phosphatase, gamma glutamyl transferase, 5 transpeptidase, 5 nucleotide days, all of them will be strongly elevated. So you see, in case number 3 and 4 and 5, in all these cases there may be elevation of hepatocellular enzyme as well as canalicular enzyme. But if hepatocellular enzymes are very high or canalicular enzymes are slightly high, it must be hepatocellular injury. Or if canalicular enzymes are very high and hepatocellular are mild to moderately high, it must be dominantly obstructive problem, cholestatic. Is that right? Another way to look the situation is that if there is obstructive problem, then what really happens? In early course of the disease, canalicular markers go up. And later on, if obstruction remains for a long time, then cell damage starts and transaminases also appear. So if a patient of jaundice comes and you repeat his liver function test over a few days or weeks, you find initially alkaline phosphatase and its friends go up, and later on, gradually transaminases go up. Problem started as obstruction. But if another patient comes to you and in his blood initially there is very high level of AST, ALT, and gradually then canalicular marker like alkaline phosphatase and its friends go up, then we call this hepatocellular injury to begin with, leading to cholestasis due to swelling of the blood and due to the membrane canalicular membrane dysfunction. Is that right? Now, then in these patients, if there is full obstruction, of course, a very important thing, there is no urobilinogen in urine. But in the urine, conjugated bilirubin which goes to blood, it is water soluble. So it can appear into urine. So there will be choluric jaundice, or there will be urinary bilirubin is present. Bilirubin is very high. Now look here again. Whenever there is obstruction, urinary you can say urobilinogen become absent, because no conjugated bilirubin is going to the GIT to be converted into urobilinogen. But conjugated bilirubin spill into circulation, and that also spills into urinary system, because conjugated bilirubin is not plasma protein bound, so it easily spills into circulation and it is water soluble, so it appears into urine. So we can say urine will turn which color? Dark color. Urine will turn due to presence of the you can say conjugated bilirubin, urine will turn dark color. Opposite to that, what will happen to GIT? Because conjugated bilirubin is not coming to GIT, GIT is not making urobilinogen or stercobilinogen, so stool will become clay colored or light colored or pale colored, right? So dark colored urine and light colored stool with urinary absence of urobilinogen and elevation of level of bilirubin in the urine, right? It all indicates what type of obstruction is there. It only tells that there is obstruction, obstructive jaundice. It does not tell the type of obstruction. It just tells that obstruction is there.